This set of slides provides an overview for measuring, caring, and nursing. It has a really heavy emphasis on instrumentation and kind of classic approaches to instrumentation, some of which has to do with item scaling. So when you're looking at creating an instrument or evaluating an instrument that measures caring or any other construct, you have to really look at what is available so that you can get the best in terms of reliability and validity to measure the attribute of interest. Remembering that measurement is important because it basically gives you what some people think are more objective data in relation to some subjective phenomena. Now you can argue this all the time, but the instrument essentially, or the device, pulls the data from the subjects, from the objects, from charts, or wherever you want the data source to be that provides or generates the data through the instrument. So you have to consider direct and indirect measures of concepts or constructs. And essentially, direct measures get closest to the validity of an instrument. And the best examples I can give for that are when you look at direct measures that are available in clinical settings that get to, for example, mean arterial pressure through a transducer and a recorder and a monitor. Indirect measures basically have to do with measuring abstract constructs, and really caring represents a more abstract concept than, let's say, a physiological concept. So when you're looking at measurement, you're getting to think about rules that assign numbers to these objects so you can quantify them. But they vary day to day depending on who the participant is as they respond to it. So the idea of variability is very important, even in terms of the way people have changes day to day, but you're trying to quantify that construct in the moment when you measure it. There's always a relationship between measurement and data collection, so you have to think about that, especially for the area of where it fits in a study. Here is something from Google that really addresses random and systematic error. And a lot of times you can take care of systematic error by the conditions under which the instrument is administered, and also the way the instrument is constructed. You have a more difficult time getting rid of random error because subject variability or state can have an impact on that. The same is true in terms of this image from Google that talks to you about the fact that you're always going to have measurement error. Even the most perfect gold standard that measures a physiologic construct has measurement error, and that is represented in statistics. Looking at psychometric instruments and questionnaires, the best way to think about development of them, if you're going to do that, is to create a blueprint. You may in fact have a theory that guides the instrument development. So that's important to make apparent to everybody who's going to use it. You can also search the literature and get to connect on a map, on a table for a study, how the items link to very specific instrument, let's say on the construct of caring. You can also conduct a qualitative study and use the themes or the codes as the basic for item development. People who live and basically breathe and experience can also be considered the originators of some of the items for an instrument. Remember that when you're talking about particularly an item, that is the stem, and you also have distractors. The distractors are the scale, and a lot of times that language is applied to tests. The stem is the stimulus, and the distractor elicits the response to the item stem, or it kind of pulls it out of the participant. So think about defining the construct in a conceptual way, a synonym type way, because the instrument will help you operationalize the concept. You have to think about the items and the number and the fit with the participants age-wise and developmental pattern and cognition, for example, so that the instrument fits them. Think about the scaling in terms of nominal, ordinal, interval/ratio scaling. Create the blueprint, and then think about how you're going to construct the items. Watch your grammar, watch your typos, watch for bias, and also construct a readability level. Seek item reviewers, and this is really important in terms of establishing the special kind of content validity called expert validity. And there is, of course, not only item means, but a content validity index for you to basically use. Pilot it before you administer it to the participant you're interested in, and then you go forward. So getting that pilot going, you should have at least 10 subjects per item. A lot of times people don't do this. This is the best advice though. If you're going to basically have a large study, you need to think about factor analysis and having 10 subjects per item. You can conduct inter-item or item-item correlations, look at the statistics, pick the items you want to retain, and then basically conduct reliability studies that we'll talk about later, such as test-retest reliability, Chromebox alpha, parallel forms reliability, and the like, inter-rater reliability too, and then validity studies. There's a whole host of them, from content validity through constructive validity to predictive concurrent validity to think about. Compile norms. Always know that you're going to be testing and retesting this instrument, and then get the paper published. So make sure that your instructions are clear. You can run the readability level obviously separate on the instructions. Make sure that basically that they're created in an unambiguous, brief way. Make sure that you go from simple to complex if you can, and have kind of a balanced kind of format in terms of the orientation of the items. Maybe you need to group the items that have the same response format, but I would advise you to basically use the same scaling throughout if you can. Making sure always that you're fitting the instruments to the participants, paying attention to readability or grade level and length and so forth. Scales that are important are nominal, ordinal, interval, ratio scales. Ratio scales go from 0 to 10, and you basically can do some testing on that in terms of magnitude. Likert scales are ordinal scales. There are a bunch of them to look at. Semantic differential scales, bipolar adjectives, are 7-point scales. Here's an example of a chart that basically has you to understand levels of measurement, nominal, ordinal, interval, and ratios on the horizontal, and on the left you can have the characteristics, distinctiveness, ordering and magnitude, equal intervals, and absolute zero. Remembering also that sometimes people statistically group the equal interval level data with the absolute zero or ratio level data. There's always a measurement controversy, and essentially people like or don't like the fact that you can sum ordinal scales to make a total scale. So people go back and forth in terms of this controversy. I put here examples from specific carrying instruments. Perceived carrying, one item, can be scaled on a visual analog scale, a 10 centimeter line with 0 and 100 millimeters at both polar ends. That's ratio level. Perceived carrying total score on a Likert or rank scaled item. Basically that means you're tallying up or the ordinal scale items to get a total score, and that's interval level. One item on a perceived carrying instrument has a Likert scale, agree, disagree, that's ordinal level. And then the carrying checklist item can be observed or non-observed, observed 1, non-observed 0, and that's nominal level. So look again at examples of nominal level scales. The definitions are on the left in terms of mutually exclusive, collectively exhaustive, and that's it. Special case of nominal scale is dichotomous scaling, and there are several examples on the right on this slide which you can look at, and perhaps they will be some of the demographics that you'll use in a study. Again, there are some examples of nominal level categorical data for you to look at, such as gender, such as age that is organized nominally or categorically, and then group designation for, let's say, an experimental or comparison/control group. Here's an example of number of countries. They would be scaled in a nominal level way. Here's an example of the way marital status can vary, and also employment status can vary, and they're considered nominal level measurements. Ordinal scales, once again, mutually exclusive, collectively exhaustive, rank ordered. Here you have a one-item instrument where you're eliciting patient's general health perception from very good to very poor. An attitude scale for one item, strongly agree to strongly disagree. Adjectival rating scale, excellent to poor, all ordinally scale. Other examples, basically knowing that the intervals or the distance between the categories is not known, basically is socioeconomic status, the way it is varied here, opinion on an item, attitude scale once again, which is here, and then of course a bipolar semantic differential scale, which is bipolar in the sense that it has two opposites at either end, and it's a 7-point scale. Ordinal scale again can go from 0 to 10, and that's an 11-point scale, just another example. And then here's some examples from the Caring Behaviors Inventory, which is a 6-point scale, from 1 never to 6 always. Also here's an example from the Care Q instrument by Larson, where it's a 7-point scale, and you have these piles of 3x5 cards where the participants sort them into piles. And in this case, there are 7 piles or 7 pockets. 2, remembering that this is ordinal level data. Caring Behaviors Assessment, that basically is one of the instruments that's out there, uses a 5-point Likert scale on perceived importance of a behavior from little importance to very important. Delphi techniques are also used that involved several rounds, usually 2 or more, of basically eliciting data from experts. So it's considered an expert response kind of study. And a lot of times the rounds start qualitatively or open-ended items. Sometimes they use close-ended as well. And then they calculate the means from the first item along with the standard deviations, feed them back into the next round with hopefully the same participants, and then they go forward. And there's an example from the caring literature of one such study. Visual analog scales basically can be used as ordinal or ratio level scales. So sometimes you're going to see them like this, where no caring is basically 0 at the end, and nurse caring as good as it can be, which is 100 millimeters or 10 centimeters at the other end. But sometimes you're going to see markings from 0 to 10 on the scale. In that case, it will be ordinal. If it's just looking like this, it would be ratio level data. Ordinal scales then, remember, are mutually exclusive, collectively exhaustive, rank ordered. There's some examples from the Caring Behaviors Inventory for elders with some statistics related to the data being summed, so it's interval level data. The same is true of the Care Q instrument, and also basically not only the monitors follows through item, but also the anticipates subscale item. So interval scales have this characteristic: mutually exclusive, collectively exhaustive, rank ordered, and here where you get into equal intervals. So there's a total score in the Caring Behaviors Inventory 42, 24, and 16. Basically for the one for elders as well. There's a sum of item responses. Not everybody uses that. Sometimes they use mean scores for each of the subscales and the overall. Knowledge test score related to nurse theorist, and here's the array of the theorists. Basically, what do you know about them? And here's another example of the sum of item responses. Ratio level data is defined as mutually exclusive, collectively exhaustive, rank ordered at equal intervals with an absolute 0. So that gets you into the magnitude idea, in that you can say twice as caring, and so forth. So the caring nurse visual analog scale, basically the respondents might answer 0 on a 10 centimeter line because they had a disastrous experience. In that case, you would treat the data as ratio level data for your participants' data. So remember that with ratio scales, there's a 0 point you can multiply and divide across a ratio scale, and essentially weight is used always as an example, but you can look at the 10 centimeter line being twice as long as the 5 centimeter line in terms of the mark on the line of that visual analog scale, for example. So total scores on a construct or concept are based on the responses, and basically you've got to give storing directions so that people